pasamos a nuestro último ponente, la doctora Meg O'Brien, que es directora de la Iniciativa de Acceso Global al Manejo del Dolor. Bienvenida, doctora O'Brien.
Gracias, buenos días. I will continue in English. My name is Meg O'Brien, and I'm the director of the Treat the Pain program at the American Cancer Society. We believe that the treatment of pain is important. You've heard about its role in end-of-life and palliative care, but I think there's other roles for it as well. We know from looking at the data that if we don't do a good job treating acute pain, that can lead to chronic pain syndromes. We also know in the treatment of post-surgical pain that failure to adequately treat pain after surgery leads to poorer outcomes and decreased mobility. We have some evidence that's growing continually that good pain relief and palliative care for cancer patients prolongs survival as well as decreasing symptoms. And then finally, from an oncology perspective, one of the things that I think we have very clear evidence of is that pain is patients' greatest fear, particularly around cancer. And that as long as people in the community think that cancer means unrelenting, uncontrolled pain, they will be afraid to come in for care. And it is a major factor in contributing to the delayed care seeking that we see in a lot of places. So now we'll talk a little bit about the situation. This is data from 2011. Globally, 7.3 million people die of HIV or cancer with moderate or severe pain each year. About 2.7 million of these deaths in pain were untreated in 2011. And you can see in this map, the countries with the darker blue are countries with more untreated deaths in pain. More than 99% of these untreated deaths in pain were in low or middle income countries. Low and middle income countries are home to about 70% of deaths from cancer and 99% of deaths from HIV, and yet they consume just 7% of the world's opioids. So the disparity is great. As you can see in this slide, quite simply, the access to pain relief is very much a factor of national income levels. High-income countries are able to meet the need for pain relief from HIV and cancer. Middle-income countries are doing better, but they're not at 100%, and low-income countries have the lowest treatment coverage rates. However, I would probably approach this data with a little more hope than if we look at data from before 2007, which I've seen. If we look at the data since 2007, we'll see that there is a trend that globally we are moving very clearly and definitively towards increasing access to pain relief. The treatment coverage rates have gone up globally, and the greatest gains have been in middle-income countries. So this is where we are seeing improved access over the last 3 or 4 years, and I hope that we continue to see them. Low-income countries still lag in coverage rates, but we are moving in the right direction in low-income countries. But I think it's middle-income countries where we're really seeing improved access to pain relief. Felicia asked me to talk a little bit about the work that we do. We're a small program, only about 3 years old, and only 5 people. Our goal is to improve universal access to essential pain medicines by the year 2020. And we do that by developing high-profile projects in countries with large unmet need. And we work in 4 key areas. The first and our main focus is strengthening government leadership. We also work on reducing the cost and improving the availability of medicines by solving supply-side challenges. We work on improving clinical and regulatory policies and practice. And finally, we focus on improving the skills and motivation of individual clinicians. I wanted to introduce here the framework that we use. The approach that we use in the countries where we work, we call a mechanism of access approach. And that means that we focus on components of the national response to untreated pain. And we've developed something that we call the morphine framework. It's a step-by-step framework for looking at challenges within a country. And I won't get too far into the details here because we don't have time, but at the very first step is mindset. It's ensuring that policymakers understand the issues and that they're prepared to take a lead role in solving the problem in a country. Step 2 is organizing, and that's consulting various stakeholders to map the process in a country and to identify barriers to access. In step 3, we look at regulations, ensuring that they're up to date and identify any changes that are needed, with a particular focus on storage, distribution, and prescribing practices. In the 4th step, we look at procurement and work with national procurement agencies to establish a budget for drug purchases, to work with suppliers to get prices reduced, and to ensure that there's a timely system for working with the INCB on estimates and replenishing the supply as it gets used. Once these 4 things are in place, we've got a supply, and we move forward into looking at demand side issues. We start with healthcare workers, organizing awareness-raising programs and training programs for health workers. Then we work on initiation, which is establishing pain treatment by trained clinicians, usually starting at large clinical centers and cancer centers. Once that's been established, we can move towards nationalization, which is integrating pain assessment and treatment into service delivery at every level of the healthcare system. And then finally, we work towards empowerment, which is creating a sustainable stakeholder base in a country, as well as sustained financing for pain assessment and treatment. Here, I'm not going to go into too much detail, but I wanted to show you what that organizing step looked like in Nigeria. When we first came to Nigeria in 2010, there had been no opioid analgesics in the country for about 18 months. So the first thing that we did was to map the process. And this is a step-by-step process of what it takes, what things have to happen for a patient in Nigeria to get access to opioid analgesics. We did this in about 4 days by traveling around the country and meeting with different people in the process, from patients to nurses, physicians, and the Ministry of Health. The next thing that we did was to identify barriers. So we identified every place in this chain where things were going wrong. This was everything from the supply side and procurement, but also looking through for physicians, lack of awareness among patients. And then we decided to come up with the list of solutions. So for each of these challenges, we worked together with the Ministry of Health to identify solutions that we could put in place to remove these barriers. And then finally, this became the work plan for the national government in Nigeria. And so we have here each of the process steps that we identified, the challenges that were identified, and then the solutions that were identified. This became the basis of a 3-year partnership between our organization and the Ministry of Health, and we added staff to the Ministry of Health to work on this work plan. I'm not going to get into too much detail about our country programs because we're running out of time, but I wanted to highlight some of the progress that we've seen. In Nigeria, I'm proud to say that the government has procured and is now distributing 21 kilograms of morphine. That is just under 50% of what Mexico consumed last year. The price for patients has decreased by between 80 to 90% depending on the facility, but it is now being delivered for about $3 per week for patients. A second procurement of morphine is underway at this time. We also work in Uganda, where we've established a local manufacturing facility for oral morphine that is based in a hospice. They've completed their initial contract with the government and produced 47 kilograms of oral morphine solution that was distributed by the government over 2 years and given to patients at no cost. So that contract has been renewed, and they're now entering the 3rd year of production. We recently facilitated a product donation of 85 kilograms, which should supply Uganda for the next 2 years and generate a revenue access that will allow them to make substantial investments in upgrading their production facilities. We've also brokered a product donation of 50 kilograms of Rodin preservative. This is actually enough for the whole continent, and we're now beginning to distribute it to countries. We've distributed all of the preservative used in Nigeria that will supply them for 5 years for free. And now we're starting, I think we've got a shipment going to Swaziland this week, and we'll start moving into other countries. We've been working with the government of Kenya over the last couple of years, and I'm very proud to say that we now are seeing the first state-sponsored procurement of morphine in several years, and that's 22 kilos. In India, we're implementing a project that we call the Pain-Free Hospital Initiative, which is a training-based project in 3 cancer centers. And initial results look positive. In the first cancer center that's reported in Talasheri, we've seen a 65% decrease in average pain scores among inpatients, simply by improving training of physicians and nurses during lunchtime training sessions, 1 hour each, and by integrating pain assessment into routine data collection. So patients now get pain scores measured every time they get vital signs measured. We've seen a huge improvement. So together, these outcomes alone have resulted in more than 2.8 million days of treatment. And as I mentioned to you before, this was done with support of 5 staff worldwide. So I think my point here is that there is a lot of low-hanging fruit. There are a lot of places, particularly if we partner with government, and to make real meaningful changes and improvements in access to pain relief. And that's it. Thank you very much.
Muchas gracias, Meg. Vamos a pasar directo a la siguiente sesión y sugerimos, vamos a tener un diálogo interactivo de preguntas y respuestas durante la comida y después de la siguiente sesión para ganarnos un poquito de tiempo. Muchísimas gracias a todos los que vinieron con nosotros y por toda la sabiduría y inspiración y esperanza en la tierra.
Damos las gracias a nuestros ponentes de esta sesión.